At this meeting, we saw a good number of updates on data that would allow us to refine the selection of processes and treatments for second-line therapy. We're very fortunate, but we're also challenged. And the reason I say we're challenged is because a couple of years ago, it had become very clear. You have myeloma, you get the first relapse. The best data was coming forward was a combination of monoclonal antibodies and carfilzomib, such as was with the studies Candor and Ikema. With pretty good results, sometimes with 3 years plus of disease control for some of those patients. But then came the CAR-Ts and the bispecifics, and we'll talk a little bit more about that of a poster we're doing. But the question now is, should you use a CAR-T now that they have the FDA approval, potentially as the therapy for your very first relapse? Along with that came with the bispecifics. Now the bispecifics are being reserved for further down the line at this moment, but there will be a future where they will be competing right there. And just as we were doing that, I say now that belantamab came raising its hand. Hey, don't forget about me. I'm not in the market, but I'm going to present you the Dream 7 and the Dream 8 studies. So we have to rethink a little bit where we are. But as of today, the big distinction is whether you would use a triplet regimen, such as I mentioned, like with a Candor regimen, or whether you would think of that patient going on to a CAR-T. So you have to consider, of course, prior therapies, tolerance to the treatment, status of the patient when they are needing that therapy, and so forth. But we're excited because of the numbers we're seeing and the durability of some of those responses.